Well, hi everyone. Good to see a few familiar names today. Well, so today's seminar is hosted by the Center for Digital Transformational Health and co-hosted by the School of Computing and Information Systems at the University of Melbourne. This event is also endorsed by one TRCB point, so please retain your Eventbrite registration ticket for proof of attendance after this seminar. I'd like to introduce our speaker for today, Professor Karin Verspoor. Karin is the Director of Health Technologies at Melbourne School of Engineering at the University of Melbourne and the Victorian State Harbour Lead of the Australian Alliance for Artificial Intelligence in Health. Karin has extensive experience in text mining and data analytics in biomedicine and has spent 5 years in startups building natural language processing systems. Karin's work ranges from literature mining of biological events, analysis of social media for public health purposes, and predictive analytics and machine learning. So today, Karin's going to present on using real-world evidence to investigate clinical research questions, and we'll have some time at the end for any questions and answers.
Great, thank you, Dawn, for the introduction. So I'm going to be talking to you about using real-world evidence for clinical research questions. And I'll start by motivating why we want to do that and then move into some of the challenges and opportunities that we have by thinking about the use of real-world evidence for clinical research. So first, let's just set a stage. The context in which we want to do clinical research ultimately is in order to collect evidence. So for a given drug or treatment or intervention or some sort of care protocol, we want to understand, does it work? Why does it work? How well does it work? When does it work? Is it safe? What are the factors that impact how well it works? What are the side effects? And so clinical research really encompasses a whole range of questions like these, for which we need data to support the evidence and the conclusions that we draw from the data so that we can effectively answer these questions. We do this because we believe that evidence is important to guide our decision-making in medicine and the choices that we make in diagnosing and treating patients. And really, we have built this kind of evidence pyramid where we have different levels of evidence that we trust in different ways. And so there's the pyramid there. And the top of the pyramid, really the gold standard of our evidence pyramid, is considered to be systematic reviews of randomized controlled trials. So by looking at carefully controlled studies where we have a clinical population that's being studied and a control group or a comparator group that we are making a contrast with, we hope to infer with some probabilistic statistical significance the evidence for a particular intervention. And when we do this, we always define a very controlled group of patients that we are studying, or a population that we want to study. And so the paradigm of randomized controlled trial really is about that controlled cohort selection, having very specifically defined inclusion criteria and very strict exclusion criteria. And essentially this whole process really embodies the scientific method. And evidence in this context then is scientific conclusions that are drawn from this very controlled experiment or controlled study of these populations. And this is a really important part of medicine, because we don't want to make decisions that aren't grounded in proof, right? In some sort of evidence that we have confidence in. So the systematic reviews are really about trying to synthesize evidence across a number of these randomized controlled trials, because every randomized controlled trial focuses on a particular patient population drawn from a particular source. So, it might be a particular hospital, or it might be a particular clinical practice, but it's a relatively small group of people. And so in order to kind of have broader evidence that applies more generally across different kinds of populations, we need to look at the evidence in those different trials and synthesize them and do meta-analysis. And the structure of a systematic review is really to very carefully define the elements of the studies that we want to do that meta-analysis for. And this framework called PICO or PICOS has been developed to guide that kind of synthesis and of the evidence. P stands for the patient or the problem or the population. That is the focus of the study. And that includes the inclusion and exclusion criteria that define that population. I is the intervention, so whether it's a drug or a digital health app or some sort of treatment protocol that's being investigated, that's characterized by I. We have our comparator or our control group, and we have an outcome that is the sort of key outcome that we would like to measure. And S is then the study design or the paradigm in which the trials have been conducted. And so really a systematic review answers the question, or the objective of a systematic review is to assess the effects of some intervention compared to some comparison group for some condition or problem in a population in a particular context on the outcomes of interest. And so that's a very general kind of template, but essentially almost all systematic reviews kind of fall into that template. And obviously their details will depend on the particular outcomes of interest and the particular population group that's being studied. So these systematic reviews played a really important part of the evidence-based medicine framework. But it turns out that in practice, often the patients that we're making decisions about do not correspond exactly to the inclusion and exclusion criteria for a particular study. So here's an example of a specific study on antipsychotics, where the inclusion criteria include that the patients needed to be male and that they needed to be within a weight range of 20% of ideal. So essentially that means healthy, non-obese males. They also had to have had schizophrenia for this particular study, so that already kind of narrows and focuses the population. In addition, there were exclusion criteria, so any patients that had a heart rate of less than 55, and also they couldn't have had acute exacerbation of schizophrenia in the last 60 days were excluded from the study. Okay, so the definition of those inclusion and exclusion criteria is really important for the paradigm of scientific investigation and controlled study. But the problem is that in a real situation, a clinician will see that study and be trying to apply it to a patient who may or may not satisfy the inclusion and exclusion criteria of that patient. And so here, if we think about this caricature patient that I put on the screen, we have a relatively obese female. Now, can we assume that the results of the study that were performed on average weight males would apply to this particular patient? We don't know, really. The evidence isn't there. We don't have evidence that we can look at. And so what's involved in trying to make that decision is clinical judgment. And that really, relies on a very non-scientific kind of body of experience and training and so on, that allows the clinician to make that decision. But there's no black and white here, right? We can't say this patient is exactly comparable to the study group. And so therefore the evidence is slightly less clear for this particular patient. And in general, there's been some studies on the representativeness of clinical populations that are studied in randomized controlled trial. And to take that same study example, which was the focus of a particular paper that I've cited there at the bottom, they they looked at the kind of overall population and looked at how many people would fall into the inclusion and not into the exclusion criteria of the study. And clearly the study there was focused on schizophrenia, and so that already brings you down to basically 1% of the population. That seems to be an okay thing to do, because we are specifically focusing on antipsychotics and schizophrenia in that study. But the more constraints you add, the smaller and smaller the population is that's even relevant to that particular study. And so you start with a target population of 3.6 million, and you end up with 632 patients for this particular study that are even eligible to be participating as the population, the study population for the study. Now, whether you can get all 632 of them to be recruited to your study is like a whole different question. But the basic point here is that even with a very large population, once you start applying these constraints, you end up with a very small pool. And if we assume that we can't have everybody who's in that pool participate in our study, and that we're only going to get a subset, we really have to question whether these populations that we are studying in the randomized controlled trial paradigm are representative of the broader population that we ultimately need to be treating. And this kind of example plays out in many, many different ways. So there's evidence that 86% of clinical trial participants worldwide were white, based on a study in 2014. Studies in general, in both basic science and in clinical populations, predominantly focus on males. And indeed, females are disproportionately excluded in clinical trials because of secondary criteria often. So for instance, if you have an age restriction, then women will often be excluded, because disproportionately excluded, because they tend to live longer. So if you ignore, if you exclude anybody who's over the age of 80, you will exclude more women from the potential population than you will men. And similarly, by excluding pregnancy as a particular comorbidity that you want to control for, again, women are going to be disproportionately excluded. And so it turns out that, like, for that clinical study on schizophrenia, not only were females completely excluded just as the basic criteria, we have the problem that actually we need to make decisions about women who are pregnant, who may or may not be suffering from schizophrenia, and whether they should be treated using these drugs. We just can't make these decisions. 79% of genomic data comes from people of European descent, even though they only comprise 16% of the world's population. And another example is a recent analysis of phase 2 and 3 randomized controlled trials examining sleep medication found that only 0.4% of the self-reported insomnia patients met all of the eligibility criteria for the study. And so the key message here is that the inclusion and exclusion criteria that we're adopting for these randomized controlled trials are really not representative. And the studies that we're populating for the populations that we're studying for all sorts of things, including genomics and molecular biology, really are not representative. So we have this gold standard of randomized controlled trials that is being used as our evidence source in medicine. But they're limited. They're limited by design because of the requirement to follow the scientific method, by these inclusion and exclusion criteria. And of course, they're limited by resources. Limited patient cohorts can be recruited for these things. So essentially, our studies are really focused on relatively healthy patients. We exclude all sorts of comorbidities. We exclude older people. We exclude a lot of the things that make people people. And so that means our studies really may not generalize to the typical patient that needs to be treated. So my question is, what about everyone else that doesn't satisfy these criteria? So one way we can think about dealing with this is to do some natural experiments using the data that we're collecting in the context of clinical care. And the idea here is that we have data resources that we're collecting about real people. Real people go to see their doctor, they go to the hospital, we collect information about them. And so possibly we can think about changing this paradigm of running controlled experiments to thinking about how we can leverage the data that we're collecting anyway about these patients in order to conduct a kind of natural experiment through this lens of the data that we're collecting about the patients. This, of course, raises a number of questions, which I have here on the screen. So what data can we use for this purpose? Is it sufficient? Is it of sufficient quality? And importantly, how can we leverage the data to gain insights? And is it possible to simulate the scenario of a randomized controlled trial through the use of observational data that's collected in the natural course of clinical care? I don't think we have all the answers on that. So what is this data that we might have access to? Well, there are kind of three main types of data that I have observed. And the most commonly used data is the administrative coded data. So these are often used in the context of population studies, epidemiological studies. And this is really the information that is provided to, for instance, our Victorian Department of Health and Human Services from hospitals. It might be Medicare data, it might be billing data that's used for payment, but essentially it's a very brief summary of a particular patient episode that then is reported primarily for the purpose of supporting basic tracking of the burden of health problems in the population, and also for funding and billing purposes. And a lot of the data that we see being analyzed is at that level. And I put it here on an iceberg because it really, to me, only represents the tip of the iceberg. It's very, very high level summary data. So for instance, a patient that is admitted to hospital in Victoria may be in hospital for 6 weeks. And at the end of that 6 weeks, a set of up to 40 codes from the International Classification of Disease will be sent to the Department of Health in something called the Victorian Admitted Episodes Dataset. Now, boiling down 6 weeks of care to, probably 5 or 6 ICD codes is arguably not a very deep representation of that patient's health situation. So the next level of data that we might consider is clinically collected structured data. So this would be things like laboratory results and pathology results and so on, vital signs that are collected in the hospital and recorded, hopefully, in an electronic health record of some sort. And there's quite a lot of this information, and it's definitely a richer source of information. And one thing that I'll come back to in a little bit later in the talk is the fact that we also collect a huge amount of unstructured data, which at the moment is really very understudied. And by that, I'm referring to things like the notes that are taken on a daily basis for patients admitted in hospital, even things like discharge summaries, radiology reports, and so on. We'll come back to that. So the key idea of using clinical data is to look in an electronic health record system. And we record quite a lot of information here. Some of this does get reported in the administrative data, like the demographic information typically is reported, but much of this doesn't ever make its way into that data. So vitals and other measurements, physical examination results, laboratory test orders and results, lifestyle questionnaires, diagnoses, prescriptions, procedures, images, information about past history of the patient, medical history, and the family history of that patient is all collected in an electronic health record of some form, and is potential data that we can think about using for this kind of evidence-based medicine methodology. And one important component of this is actually standardizing and normalizing the representation of that data so that we can essentially understand the information that's in there and relate information from different sources and different electronic health record systems together. So, for instance, the administrative data that reports the ICD codes, it's important that we have this vocabulary of ICD codes because it defines essentially what we mean when we use a particular term. So when we assign a diagnosis like breast cancer, that comes with it a certain set of assumptions about exactly what we mean by that. And so assigning an appropriate code allows me to say that this patient over here in Royal Melbourne Hospital is comparable to this patient over here in Royal Women's Hospital. And it allows us to relate information together. And there are a number of these coding schemes that have been developed by the health informatics community, including the ICD codes, but in the UK, they've been using something called READ codes. We have medical subject headings that are used for a lot of the literature annotation and also can be related to some of these other coding systems. SNOMED CT, which is a controlled vocabulary of clinical terminology, more like symptoms, signs and symptoms. And then we have dictionaries of medicines and devices, which again provide standard representations. We can also leverage structured documentation like care pathways and templates and other aspects of structured data entry that are supported by electronic health record systems. And to the extent that they adopt kind of standardized representations like FHIR and the OMOP Common Data Model, this allows us again to compare and contrast information that's derived from different electronic health record systems. I also want to talk about a study that one of my PhD students is working on. And this is Jake Valentine. He's well into his PhD, doing some great work. And one of the projects that he's been working on recently is a comparison of the use of the administrative coded data with the actual clinical data in a particular context. So his context is in infections and cancer, and specifically this study looked at the detection of invasive fungal infection in pediatric cancer patients. He did this via a retrospective cohort study at the Royal Children's Hospital for cancer-related hospital admissions between 2004 and 2013. And essentially what Jake was trying to do was to measure whether the codes that were captured in the administrative data sets via ICD reflected the clinical diagnosis that was actually available in the chart of these patients. And so leveraging a data set called R-Terrific, where clinicians had done a manual chart review and actually identified all of the patients in that cohort that had a clinical diagnosis of IFI according to their definition. He then compared that gold standard diagnosis from the clinicians with the ICD codes that were associated with those same patient records, and measured a number of things. And so what we have is essentially some statistics on how many of the patients matched, right? So a patient that both had an R-Terrific IFI diagnosis, clinical diagnosis, and the appropriate ICD code, corresponding ICD code, is a true positive case. There were only 68 of those in this particular data set. And all of the other ones were wrong in different ways, right? So a false positive is a case where there is an R-Terrific negative assessment. So the clinical assessment is that this patient did not have an invasive fungal infection, while the ICD codes indicated that they did. There were 46 of those. Then there's the case where the clinicians identified a patient as having IFI, and the codes did not reflect that case. So that was 45 of the cases. So overall, there are quite a lot of differences between the clinical annotation and what we see in the administratively coded data. And to put it into numbers, we can see that depending on exactly which definition of invasive fungal infection is used by the clinicians, either proven invasive fungal infection or probable invasive fungal infection, and proven is a higher standard, there are some substantial differences between these different coding sets. And so the real takeaway from this study is that there is a disconnect between what we are coding in the administrative data sets and what a clinician would define as IFI. Now, this doesn't necessarily mean that the codes are wrong or missing in some cases, but it does mean that there is a lack of agreement between the definitions and the specification of what this clinical diagnosis is. And for those of us thinking about leveraging administrative coded data, it really raises the question of the completeness and the clinical relevance of the definitions that are used to structure and annotate this data. And then it really raises that question of whether it's feasible for us to make use of that administrative coded data in the context of trying to understand our clinical populations. So moving on to the clinical data, if we think about that collection of clinical structured data, one paradigm that we might have is to think about patients as a sort of bag of concepts. And so we can map our patients into the conditions, the drugs, the measurements, and the procedures that have been done to them. And if we plot that over time, so this is intended to be sort of a timeline here. And the way to read this is at time 1, this particular patient had this procedure. At time 2, they were given this drug. At time 3, they were observed to have this particular symptom or condition or diagnosis. Then they had a procedure at this time, and so on. So we can sort of map out the patient experience by time-stamping particular clinical events and associating those events to a kind of model of what the patient is experiencing. And then we can think about running kind of studies against this by anchoring particular points in time and asking questions about that. And so if we, for instance, are interested in studying a particular treatment, a particular drug that's given, we might break down the information that we have about this patient into, okay, what was going on with this patient before treatment and what has happened to this patient after treatment. And we might say that the outcome that we're interested in that sort of PICO question is a particular condition and whether or not it has occurred after the treatment time. And that allows us to answer particular questions. The kinds of questions we can answer really fall into 3 categories. We can count things, and we can call that clinical characterization. So we can count how often particular patterns occur. We can do some population level estimation, so look for probabilities. And we can even attempt to do some patient level prediction by grouping patients on the basis of their shared characteristics. So if we go back to that kind of that timeline and the collection of conditions, procedures, and measurements and so on that we have about the patient, we can ask these different kinds of questions. And I've color coded. So purple is clinical characterization, the blue is population level estimation, and the black is patient level prediction. So the questions we can ask about this using this kind of data are things like, what treatment did the patients choose after a particular diagnosis, or were they given after a particular diagnosis? We can look at the patterns there. which patients chose which treatment. So we can try to cluster or separate, stratify the patient population on, oops, sorry, I went the wrong way, on the basis of their particular characteristics, like the conditions and measurements and procedures they've had, in order to try to understand what the characteristics of patients who chose one treatment over another might have been. We can ask how many patients experienced a particular outcome after the treatment. We can ask questions like, does the treatment cause the outcome, by looking at a whole population of patients that have had this treatment and look at the relationship statistically between the treatment and the outcome across that population. Does one treatment cause a particular outcome more than an alternative? We can ask these kind of comparative questions, again, by just leveraging the data that's in the clinical record. And then at the more individual level, we can start to look at the probability that a particular individual will develop a disease, again, on the basis of their collection of history that's embodied by this data set, and the probability that they will experience a particular outcome. And so we can really start to ask lots of questions which can be answered statistically by looking at the data that's in the database. So, you know, a point that I made earlier was about the representativeness of the populations that we study. And I think if we think about that in terms of these sort of concentric circles of ever increasing population size, we can really see the power. And, you know, that's both a statistical term and a motivational term. We can see the power of trying to leverage larger population sizes. So, you know, the bigger the population that we can draw from is, the more significant the statistical analysis will be. And so the sort of stronger evidence for particular questions we can find. But it also allows us to have more representative populations. And so it's kind of by leveraging the power of data to bring together larger and larger and larger data sets, we can really potentially start to gain much more insight with much narrower confidence intervals into what's actually happening. And furthermore, it can start to address the representativeness of the population, because even if we start to stratify our data sets into smaller and smaller groups based on certain characteristics in the inclusion and exclusion criteria, we can still ask questions because those patients will be there in the database. Just to give an example, we recently did a study with the UK Clinical Practice Research Database data, which contains data for 19 million patients. And we were interested in investigating the health risks. So probability, the outcomes we were interested in were stroke, bleeding, or mortality of patients who'd been treated with atrial fibrillation, who had atrial fibrillation and were treated with warfarin. Now, we started with 19 million patients. And just to give you a sense of what happens as we start to apply criteria, we found that we could only really study 6,718 patients in our cohort in the end. So we had to pick particular study dates. We had to look for a diagnosis of atrial fibrillation. We were interested only in patients who were at least 18 years old. And of course, because the focus of the study is on the treatment, we needed to restrict that population to receiving oral, those who were receiving oral anticoagulants. And then we had a number of other exclusion criteria. And at the end of the day, we went from 19 possible patients whose data were in this database, to less than 7,000 that we could study. And I won't go through all of the details here, mainly because I'm talking too much. But just to give you a sense, we applied machine learning to this, and in fact experimented with a couple of the sort of neural methods that are now popular in machine learning, and we get sort of mediocre results. And in fact, it turns out that some of the simpler statistical models like machine learning models like support vector machines and naive Bayes, in some cases actually outperform the more complex deep learning models. But you know, the story here is really not so much about the performance of our models and our predictive capacity, but the fact that we are starting to be able to try to model these populations by leveraging the large scale data. And you know, if you go from 19 million down to 7,000, and you think about trying to do that in a much more controlled and narrow population, you know, there's no way you could really even try to model this using sophisticated statistical methods without having a large population to look at. And this, in fact, has inspired an initiative out of the US called the Observational Health Data Sciences and Informatics Initiative, or Odyssey. And they published a paper back in 2016, kind of with their first attempts to get this. And it's an international consortium whereby making data available for inquiry across internationally, they're able to really start to ask some of these important questions. And at the moment, I checked yesterday, and it appears that they have 17 countries that are now participating in this, 100 databases, and reflecting 500 million people. And so you can really start to see how we can leverage the power of this. And the beauty of the Odyssey paradigm is that nobody's actually sending data anywhere. All of the data lives with the data custodians in their databases. What happens is the questions go to the data. So if you want to ask, you know, those questions that we were looking at earlier, like how many patients experience this outcome after treatment, you can simply send a request to each of these 100 databases and ask them to send you the aggregate statistics of those patterns. And so by sending questions to the data, and by having those questions be defined in very clear coded specifications, we can get numbers that are able to be modeled. Now, I'm not going to say that this is a panacea, it's going to solve all of our problems, because there are a lot of challenges in using observationally derived evidence that doesn't come from a randomized controlled trial paradigm. First of all, there's going to be massive data heterogeneity. What data we collect in different places is going to vary. There's questions about the quality of the data. There's lots of missing information, lots of errors potentially. It's not controlled, right? And so because of the fact that it's not controlled, it means that there will be missing data. There's potential for bias in how that data is collected. And really questions of causality are very difficult to explore. And so I guess I would say that we're trying to make progress on this. So, you know, there's things like the Odyssey Consortium and really the kind of statistical biostatistics community is trying to address how we can model these sorts of populations given these constraints. So algorithms for doing more robust data mining and inference, statistical inference, are really important and still under investigation. So I would suggest that we're kind of moving from this paradigm of the 4 V's in big data, which maybe you've heard about, which are volume, variety, velocity, and veracity, to what I've called the 5 C's. And my 5 C's, and excuse my little misuse of C here, but we have complexity, quality, thank you, causality, confounding, and counterfactual reasoning, which are kind of the new issues that we need to be thinking about when working with the big data, particularly in the health context, particularly for these kind of clinical research questions. So coming back to my iceberg here, I mentioned that a lot of unstructured data, there's a lot of unstructured data out there, and it has been argued that we really need to look at this unstructured data in order to describe patients in sufficient detail. And in fact, there's been some estimates that up to 70% of the information that we collect in an electronic health record system about our patient is actually entered in free text form. And so in order to get kind of deeper information about these outcomes, prognoses, treatment effectiveness, conditions, symptoms, and the clinical variability that we see, arguably we really need to be digging into this information as well. And in fact, one of the big deep learning studies that came out recently was comparing the use of only structured data from the electronic health record system with the predictive ability to utilize free text in that hospital. And they were able to demonstrate that for a number of kind of important prediction tasks like in-hospital mortality and 30-day unplanned readmission and so on, that they were able to derive benefit by using the free text. And actually in their particular approach, they used what we call a bag of words model. So basically you literally just throw the words that are in the text into the model, and not doing anything really sophisticated, they were still able to see some benefit to that. So this kind of work suggests that, you know, by incorporating the unstructured data, we can start to do a better job of characterizing. And just to kind of walk you through a little example of why this might be the case, we can look at a particular discharge summary here, and we can see that there's some sort of key information in here that's important. So we have demographic information like 68-year-old female, which presumably would be elsewhere in the record. So maybe that's not adding anything. But we have complaints here like shortness of breath and non-productive cough, chills, but no fever. And we have information about the treatments, breathing treatments, morphine, some lab results, D-dimer. So there's a lot of information here. And one thing that I think is really important to note here is that there's actually a lot of clinical reasoning that's captured in here. So, you know, after consultation with Dr. C, it is felt that she's potentially too unstable to go for a particular scan. And so we can see that if we can kind of, you know, so one thing is to go through these texts and identify the kind of key concepts that are in there, like I've captured here. But another thing is to put it into context and deal with things like the fact that, oh, we ordered the scan, but then she didn't have it, or that there was no fever. If we just run a quick scan over this and we see chills and we see fever, oh, oops, actually there was no fever. And so dealing with the negation and that context there is important. There's a lot of information in here that if we don't look at it, we're not able to use. So one project that another of my students is working on is actually in the context of veterinary texts, and I'll talk a little bit more about why veterinary texts in just a second. But just to focus on his project, so this is Dr. Brian Herr. He's a veterinarian, and he's been working with the problem of antimicrobial resistance. So in antimicrobial resistance, of course, the basic problem driving antimicrobial resistance is overprescription of antibiotics and antimicrobials. And so, and there's projections, some scary numbers here about the potential impact of this problem. And veterinarians have been under scrutiny for contributing to the rise because, of course, they prescribe antimicrobials to their patients, including dogs and cats. And it has been demonstrated that antimicrobial stewardship is an effective approach to reducing antimicrobial resistance. And one of the key components of antimicrobial stewardship is monitoring the use of antimicrobials. And how can we do that if we don't have data to do the monitoring? So in the context of veterinary records, that information is largely available in the unstructured notes that are taken during the consults. And so Brian has been working with this data set from Vet Compass Australia, which is a collection of medical records from 181 veterinary clinics across Australia, corresponding to over 20 million clinical records. And he's been able to extract consult level antimicrobial usage from this data in order to characterize the use of antimicrobials. And he's more recently been working on actually going that bit deeper into the structure of the text and work out why these particular antimicrobials were administered. And So in the example I have on the screen that Brian kindly provided to me, we see that the drug sevoflurane, and I'm sorry if I'm pronouncing that wrong, was prescribed for an ear disorder. And you can see by just looking at it that it's a quite complex text, and actually trying to work that out is quite difficult. And it also has typos and grammatical errors and so on. So text is fun. So using this approach, Brian has been able to characterize the clinical use of particular drugs, and yeah, it's quite small, so I apologize for that. And then he was able to break that down by essentially how critical the particular antimicrobials are and how problematic they are, and so, you know, we can also look across geographic areas at that use, and this gives really good insight into where the antimicrobials are being used, and then that next phase of why they're being used will also give important data around the use of these drugs, and will inform the antimicrobial stewardships. And in fact, those are currently under development. So this is an example of where we've been able to leverage the free text in order to gain clinical insights. I said I would come back to the issue of why veterinary data. Well, it turns out that dogs and cats don't care too much about privacy. So we've been able to access clinical records in the veterinary domain a bit more easily than we have in the medical context for humans. And so one project that we're working on at the moment is to have automated de-identification of these data so that we can work more effectively with the free text. And I'm running out of time, and I want to leave some time for questions, so I will stop there. But I think the takeaway message I hope you will take away are that real-world data can provide tremendously rich evidence for more representative populations, but you know, it's not completely without its challenges, and so it requires certain key elements such as the informatics challenges around developing common data models and having common definitions for our clinical concepts. The governance challenges around data sharing and linkage, and kind of thinking through different ways that we can make it possible to build up to those state level, national level, international population sizes. We have some very knotty challenges around the quality, heterogeneity, and variability of the data, and some big statistical challenges in thinking through how we can kind of transfer the randomized control paradigm into this real world data paradigm. And of course, I can't leave you without reminding you that text is a very important resource in this context. And I can give, and I probably will give, another talk all about what we're doing to leverage natural language processing in the clinical context at some point. So I'll leave it there, and happy to take questions. Thanks.